It did.
Move. Yes.
Good, thank you. That's all I need.
Dr. Martin, would you like to check your presentation, sir?
Yes. Share screen. There we go. Share. And I go to.
We can see it.
Oh, yeah. Yes, we can.
Yes.
One. So
Good.
now you should see my whole screen, correct?
Yes.
Yes. Screen.
Good.
Like the slide.
And I can go forward. Yes.
Followed with Dr. Arun Singh. Dr. Arun, would you like to share the screen? Dr. Martin, you can stop sharing the screen now.
Yeah.
Thank you so very much. Dr. Arun, would you like to share the screen?
Yes.
Please share your screen so we can check.
Yeah.
Followed with Dr. Mary.
Is that okay?
All right, Dr. Arun. Yes, absolutely perfect. You can stop sharing the screen now. Dr. Mary. Is Dr. Mary here with us? Yes.
Yeah.
Dr. Mary, would you like to share your screen, please? All right, we can see that. And Dr. Bhavna Chawla. Thank you, Dr. Mary. You can stop sharing your screen. Dr. Bhavna Chawla.
Yeah, mine is working.
Would you like to share?
No problem. Yeah, I checked mine already. Yeah.
Great.
Good evening, everyone.
Hi. Thank you for being
Hello.
here, everyone.
Good evening, Dr. Fair. Namaste. Welcome.
Hi, Mr. Hime. How are you doing?
We're doing good. All right. So with your permission, I would like to officially start with this session. So ladies and gentlemen, I welcome everybody to IOC 2022. And we have our chairperson, Dr. Carol Shields, there with us. So I would like to hand over the virtual dais to our chairperson, and then she can take it forward from here. Thank you. Welcome and namaste.
Yeah. Good morning, good afternoon, and good evening to all of you. This is going to be a symposium in ocular oncology, intraocular tumors, and I'm graced to be the first speaker, so I will share my screen.
So by the time you're sharing your screen, Dr. Carol, we have 15 minutes of presentation time for every speaker. And
so, yeah,
towards the end, we will utilize the time for discussions if it's okay with everybody. You can continue, ma'am. Thank you.
Thank you. And you can see my slides?
Yes, we can see your slide and we can hear you loud and clear. Good to go.
Okay, good. Okay, so I have no financial interest or relationships to disclose, and I'd like to speak to you on retinoblastoma, global retinoblastoma 2023. It takes an entire team to evaluate a patient and manage a patient with retinoblastoma. And in our practice, I always say it takes a village to manage a child with retinoblastoma, and we've been doing this for over 50 years at Wills Eye Hospital in Philadelphia. So global retinoblastoma, in 2009, Cavella wrote a very nice report on the challenge of the most frequent eye cancer, retinoblastoma, and he estimated that there were approximately 8,000 new cases per year on planet Earth. In 2020, Fabian et al. Looked at the year 2017 and gathered 4,351 new patients with retinoblastoma from 153 countries. This was an enormous amount of work for he and his team. And they found the median age at presentation was 30 months. However, if you look at high income countries only, the median age at presentation was much earlier at 14 months, and very few patients had extrascleral extension of retinoblastoma or metastatic disease, as compared to low income countries where the median age was much older at 30 months, and extrascleral retinoblastoma was seen in up to 50% and metastasis at 19%. And if you look at this in graph form, you'll see median age is very disparate between high and low income countries. Extrascleral extension of retinoblastoma, nearly 50% in low income countries compared to high income countries, and metastatic disease differed based on income per country. Most of this we expect is related to the dramatic delay in diagnosis or presentation in low-income countries, because there was a 16-month difference, and that allows for substantial tumor growth and tumor invasion. Then the next study by the same team, Fabian et al., which included many, many people, and many of the people in this symposium will be published in Lancet Global Health this year. Again, they looked at the same, they asked the question, what is the outcome of treatment for children with retinoblastoma around the world? Looking at the same cohort from 2017, 4,351 new patients in 153 countries. Chemotherapy was available in all the countries, and he confirmed that. And he found the 3-year survival per country for high income was over 99%, mid-high income 91%, mid-low income 80%, and low income 57%. So with all the improvements that we've made with retinoblastoma and put in perspective, we still have a lot of work to do to help all nations with retinoblastoma improve detection and care. Now, Ancona Lizama from Mexico, along with Lauren Dalvin from Mayo Clinic and our team in Philadelphia, wrote an analysis on where we stand with retinoblastoma. This was published in Indian Journal of Ophthalmology. And I'll summarize for you in this presentation. It's all about chemotherapy. Chemotherapy delivered in various ways. So we still perform enucleation for high-risk retinoblastoma, or if the family is unreliable. We give intravenous chemotherapy for bilateral retinoblastoma. Intraarterial, we still like to reserve for unilateral retinoblastoma, and we inject the vitreous or aqueous with chemotherapy if there is seeding. And plaque radiotherapy is still performed, but if all the above fails, then we go on to plaque radiotherapy. So a few words about intravenous chemotherapy. This treats not only the eyes, but we think it prevents pinealoblastoma and minimizes second cancer. Here you see a child with bilateral advanced retinoblastoma, total retinal detachment, and after intravenous chemotherapy, the retina has flattened, the tumors have regressed. She's now 20 years old with vision of 20/30 OD and 20/70 OS and no metastatic disease. But is this really lasting? Because we're only giving 6 cycles of chemotherapy? Well, we wanted to answer that question, and we published this in BJO 2020, long-term analysis in nearly 1,000 eyes using intravenous chemotherapy for retinoblastoma. And in this analysis, we looked at 1, 2, 3, 5, 10, and 20 years follow-up. And here you can see at 1-year follow-up, over 90% of groups A, B, and C did well. A good amount of group D, 78%, had their eye saved without the need for radiotherapy, and about 50% of group E. And it held at 2 years, at 3 years, at 5 years, 10, and even 20 years. So I generally tell our patients what we see at 2 to 3 years is basically what the child's going to have long-term. Now, what is the need for additional intraarterial chemotherapy or plaque radiotherapy after intravenous chemotherapy? And we looked at this in the same cohort. We tend to go on to IAC first, and that's at a mean interval of 5 months as needed, and plaque radiotherapy if IAC fails at a mean interval of 13 months. And we found overall, following intravenous chemotherapy, IAC was necessary 17% of cases, and plaque 19% of cases. So it is a little bit of making judgment on tumor control and knowing what you have available to treat and save the eye. So what about IAC? How successful are we with IAC? Well, it is successful, especially for group D eyes, much more successful than intravenous chemotherapy. especially if we can see that there is some normal retina, as in this case that showed complete response with just 2 doses of IAC. So we published last year in the Journal of the American Academy of Pediatric Ophthalmology and Strabismus our experience with 1,292 infusions of intraarterial chemotherapy for retinoblastoma. Here's one example. In A, you can see the advanced disease with B showing the ultrasound, and then following IAC in C, you can see it's beautifully regressed and confirmed in D on ultrasound. So if we look at 5-year follow-up of IAC following 1292 infusions, we have 100% globe salvage for group B, 80% group C, 78% group D, and 55% for group E. And for primary treatment, 76% of eyes were saved. So 3/4 of the eyes we can save with intraarterial chemotherapy using a median of 3 infusions. And now we've gotten to the point that our complication rate is only 1% per infusion. But honestly, it's not all that easy. This is a nice report from our team, Swide and Jabor, where they looked at alternative routes that are essential for delivery of intraarterial chemotherapy. They were successful in accessing the ophthalmic artery in 97% of cases, but in 3% of cases, unsuccessful due to poor vascular access, anaphylactic reaction, carotid vasospasm, or simply just failed to reach the ophthalmic artery. And when they looked at 207 eyes, 658 procedures, you can see 20 of the cases they needed to use the balloon, 22 middle meningeal approach, some technical failures, ophthalmic artery stenosis. There's lots of decisions that go into a single case of intraarterial chemotherapy. Overall, they achieved success in 97% of cases, but needed to use alternative routes in 6% of cases. And the median number of infusions per that team, our team, was 3 infusions. Some got by with 2, and even some got by with only 1 infusion for tumor control. The team in Buffalo wrote an editorial or commentary on their results. This commentary read, "Intraarterial chemotherapy has varying efficacy, but it is a medical success story. And the value of endovascular expertise at a high volume center is important." This article highlights that. And retinoblastoma patients should be served at a center that does have experience with this treatment. I'll move on to intravitreous chemotherapy. This is a very important modality for saving eyes with vitreous seeds. You can see before intravenous chemotherapy, and then on the bottom after intravenous chemotherapy, we still have vitreous seeds, but we clean those up with intravitreal chemotherapy. We generally give 4 injections at a monthly interval, and you can see the macula was fine in this case. We published on our first 192 injections and had 100% vitreous seed control. And then Jasmine Francis gathered data from 10 retinoblastoma centers and found there was no case where extraocular retinoblastoma was seen in any of these over 3,000 injections. Now, I'll talk about a very important topic, high-risk retinoblastoma. What is high risk and how do we treat it? Well, let's start with the latter question first. Swati Kaliki, who is one of the panelists in this session, looked at the value of vincristine, etoposide, and carboplatin for high-risk retinoblastoma and found globe salvage and tumor control, found tumor control in every case. These were eyes that had high risk following enucleation, and using those 3 agents, metastatic disease was prevented in 100% of cases. The more difficult question is, what is high-risk retinoblastoma? Well, 20 years after Swati did that first report, she published this recent report in JAMA Ophthalmology, where she defined what is high-risk retinoblastoma. She looked at patients from all the different continents, Africa, Asia, Australia, Europe, North and South America, 52 oncologists and pathologists were surveyed as to what defines high-risk retinoblastoma. And in this figure, you can see we agree and we don't agree. Here's where we agree. We all agree that postlaminar optic nerve invasion, transection invasion, scleral infiltration, and extrascleral tumor is high risk. And we also agree that massive choroidal invasion is high risk. Where we don't agree is regarding anterior chamber seeds, iris infiltration, ciliary body infiltration, trabecular meshwork invasion, and minor choroidal invasion. In Philadelphia, we believe that optic nerve invasion postlaminar and choroidal invasion more than 3 millimeters is high risk, or any combination of optic nerve or choroidal invasion. So Dr. Kaliki is going on with a multi-center study, which is underway to evaluate how we manage high-risk retinoblastoma. And I'll conclude with the psychology of retinoblastoma. What is it like to have a child with retinoblastoma, and how do these children feel? Let's talk about the patient first. In the Indian Journal of Ophthalmology, this was analyzed in a small cohort of patients, 92 retinoblastoma survivors, looking at 4 dimensions: physical, emotional, social, and school. And they found that the quality of life of these 92 retinoblastoma survivors was significantly lower compared to sibling controls in all 4 domains, but particularly in the physical domain and the social domain. And then we looked at, along with Mary Louise Collins, how do the parents feel when they have a family member with retinoblastoma? Well, the majority of parents displayed, using standardized testing, some depression, anxiety, and all felt stress. And severe depression was more often found in those who had children with multifocal disease and previous history of depression and less education. So in summary, over the past few minutes, we've talked about global retinoblastoma disparities, the magnificent work of Fabian and his team of many, many centers from around the world. We've reviewed chemotherapy for retinoblastoma, high-risk retinoblastoma from the Kaliki et al. Studies, and then the psychology of retinoblastoma in parents and patients. So this is a nice overview from the laser-focused retinoblastoma team in Philadelphia. Thank you.